Good afternoon. This is Dr. Michael Tapper from Lenox Hill Hospital, New York City, again reporting to you from the conference on retroviruses and opportunistic infections, which is taking place in Boston, Massachusetts. I'm very pleased to be joined today by Dr. Darrell Wheeler from the State University of New York at Albany, my home state, so I feel very closely connected. But we've discovered that we both have a mutual background at Columbia University and Hunter and et cetera. But you were part of a fascinating session and have done some wonderful work in the area of PrEP, which has obviously been a major theme at this conference yet again. And I wanted to ask you if you could begin by briefly describing your study and some of the implications of the work that you've been doing.
Oh, absolutely. I'm happy to have the opportunity to do that. HPTN 063, as we call it, is a study that was an open label study looking at whether or not black men who have sex with men would take PrEP. If they took it, would they adhere to it, and would they show benefit from it? Looking at some of the sociocultural demographics that differentiate men who take and don't. So we were able to recruit 226 men across 3 study sites, Los Angeles, Washington, D.C., and Chapel Hill, North Carolina. We followed all men over the course of the year. We had 209 men retained in the study, so 90%, 92% retention rate, and 178 men actually said they would accept PrEP. We saw very few seroconversions, but of the seroconversions that we did see, a total of 7 in the life of the study, we saw 5 of those occur in men who said they were going to take PrEP, but actually 2 of those men weren't on PrEP. They self-reported that they stopped taking it. So the incidence is still high, 2.9% for those who were accepting PrEP, but 7.7% for those men who weren't accepting PrEP. Really, the study is a study that built around a culturally unique intervention that was patient-centered, client-centered, and was anchored to understanding what were the factors in men's lives that needed to be addressed: housing, education, school, employment. And while we wouldn't be able to fix those issues, we firmly believe that helping men to understand how those factors affect their ability to accept or not, and then to adhere to PrEP, was really the key. So the study just ended in September of 2015. We closed the data in December, and we're really diving into the data analysis now.
Yeah, there are lots of questions you have to ask, and probably the answer to most is we haven't looked at it yet. It's fascinating to me for 2 reasons. One is because so many of the original PrEP studies were done in women, and a lot of it was done obviously in Africa,
yes,
where women's issues, women's ability to control their partners is a major issue. And now we're looking much more carefully at the left behind group in the United States. And the left behind group in the United States largely focuses, as your data showed, on African Americans and on African American males in particular.
Correct.
So, I mean, this is a group that has been challenging to reach. It's been challenging in terms of treatment. It's been challenging in terms of prevention efforts. So, I mean, I think this is a terribly important thing to try to understand what we need to do to have PrEP be effective in this population. Your study so nicely showed how we can get to the points we need to do. I was impressed by the number of people who stayed with the study and the relatively low rate of dropouts in the study, which I think is also a terribly important issue. Are there some takeaway messages? Are there things that we still need to do better? Are there things that we're still doing wrong?
Absolutely. You know, and I wish I had all of the answers, but based on the work that we did in HPTN 073 and a prior study, HPTN 061, I think some of the really important take-home messages are, first and foremost, we have to understand the sample, the population that we're dealing with. So spending time to understand what are the issues that are relevant to the men that we're trying to attract. You know, when we say things such as men are hard to reach or they don't come into the studies, it's often because we haven't built the right infrastructure to attract individuals. Doing programs that are not so female-centered. You just talked about PrEP being anchored in female populations, and understanding the dynamics of a healthcare system that often is foreign and maybe formidable to men. Helping men to understand in a stepwise process, you know, how to engage with the healthcare provider system. which often defies the healthcare provider system that wants to provide care and treatment right away.
Exactly.
And you want to go from 0 to 60, and you may need to slow up to understand, and to start where the men actually are. A cliche often used is, we like to say we start where the client is, and I like to say we never start where the client is, we start where the client is, where we're capable of being. And we're part of that equation. And we have to ask ourselves, is it our enthusiasm that overrides the ability for people to be part of the system of care because we want to move them, or is it that or are we actually listening to what they have to say and incorporating it?